Let's see. Okay. We are live. I can see my counter.
Awesome.
All right. So happy, what is it, Wednesday, everybody?
Yep. Wednesday afternoon.
Happy Wednesday. So I just want to introduce myself to all of our audience members. I'm Alana Zurich, the CEO and founder of Beverly Hills Hair Free, and welcome to Beverly Hills Hair Free YouTube channel. I am the owner of a permanent hair removal clinic located in Beverly Hills, California, and Dallas, Texas. And we now have a partnership with a location in Gilbert, Arizona, and they're called Electrolysis and Company. Hopefully, eventually, we will be global. By 2025, we hope, and we hope to have locations really soon in New York, Florida, and Georgia. But if you don't live in the above mentioned areas, don't worry, we could still treat you. We can develop a treatment plan for our national and international clientele, and we are able to create a treatment plan that works for your specific needs and your issues, including treating you just once a month. And I want to give you details about what we do, but for the purposes of this podcast, I want to introduce my brilliant guest and partner. We've recently created a partnership with PCOSsisters and Beverly Hills Hair Free. And her name is Lynsey Johnson, and she is the founder and creator of PCOSsisters. It's an online telehealth platform that specializes polycystic ovarian syndrome, also known as PCOS. PCOS is a syndrome in women with excess testosterone leading to symptoms such as excess hair growth, scalp, obesity. Is that right?
Nope. It's actually scalp hair loss. So in a
Scalp
male
hair
pattern.
loss. I'm sorry.
Yes.
Male hair pattern. Yes. Obesity, acne, mood swings, irregular cycles, and infertility. And I'm going to allow Lynsey to take over. So Lynsey, can you please tell us about you and your organization? And thank you so much for being here today.
Yes, and thank you for having me, Alana. And thank you for partnering. I'm so
Yes.
excited for what the future brings. I'm the founder and CEO of PCOSsisters Telehealth Clinic, and we are a multi-state telehealth practice. So we actually launched in 2022 in Florida and are now in Georgia, New York, and Texas, and soon to be Arizona. So we cover several states. And it's great because women can be treated for PCOS from the comfort of their own homes. So there's no travel involved. There's no trying to find a doctor that understands how to treat your PCOS. And the inspiration from this company actually came from me suffering from PCOS myself, lifelong. And this is back in the early 2000s. And you would have to go from doctor to doctor and try to find who even knew what it was, A. B, if they did know what it was, are they willing to test you for it? Do they know how to test you for it? And even if they know how to test you for it, will they treat you? So we now know that the average PCOS patient sees at least 3 different kinds of doctors before they ever receive a diagnosis, much less treatment, which is pretty ridiculous 20 years later from the early 2000s. And a lot of this is because, the guidelines, the first update was in 2023 for 20 years. Prior to that, the last update in guidelines was 2003. So things are finally starting to change. For one, semaglutide or Ozempic, Wegovy, whatever you want to call it, brand name wise, is now on the 2023 PCOS treatment guidelines. If your PCOS has progressed to the obesity point, that's a sign of major progression. It is very frustrating for women to go and have a doctor say, that's normal. The hair growth on your face is normal. Losing your hair is normal, and you are 21 years old with a full beard in some cases. In extreme, this is not a hair or two. So, sometimes it is in the beginning a hair or two, but it's progressive. So the older you get, it can get worse. And that's why it's best to catch it early. And this is a PCOS program designed and developed by PCOS women. So that's one of the great aspects to our program. And we even have discounts for the labs. So a PCOS workup, if you don't have insurance, would be $2,000. If you just walked in and said, I want all these hormones checked, we actually have prices as low as $225 for the whole PCOS workup. So that is a huge impact, allowing women from all different backgrounds to receive treatment and diagnosis.
Can you elaborate on that, Lynsey? I know you have particular programs, and you and I spoke about that. What are some of the programs that you offer, and how do you differ from other PCOS clinics?
Yeah. So we have several different, we have memberships, okay, and those include full concierge level medicine. You have a direct text line to your nurse practitioner who becomes your best friend, best buddy. You also get workout programs. Those are workout videos that are designed with your nurse practitioner in live time. Y'all work together to build it. And then also cooking videos. You also get a community support group where all of our PCOS patients chat. And you get unlimited primary care. So you can literally, unrelated to PCOS, if you have any other issue like hypothyroidism, or you even get a cold or a rash or something, you can also text your nurse practitioner or schedule a visit and video is required. Camera is required for our visits. And the other great thing about it is you don't have to be a resident of our state. We actually have people that travel to the border that live in South Carolina and drive to the border of Georgia and sit in their car to be seen. We have people that fly in, that boat in from the islands outside of Florida to be seen. So as long as the time of the visit, you are located in one of our state coverage areas, which is Florida, Georgia, Texas, and New York, soon to be Arizona, then we can see you. So a lot of people don't realize that. So we are different because we are PCOS women who have been where you are as your providers. So that's the main difference between us and everyone else. And we also follow the latest up-to-date guidelines. We're involved with research. You don't have to wonder where are they getting this information. Like, we have an education tab on our website. You can see the guidelines. You can see the research. There's nothing in question here.
That's fantastic. And then let's talk a little bit about insurance. I think we spoke about that you can do the lab work and process all of the expensive tests using the patient's actual insurance, correct?
Correct. If you have insurance, anything we order, so that could be medications, labs, imaging, covered by insurance. Okay. If you don't have insurance, we have discounts that are just about the same, to be honest, in most cases, depending on your insurance policy, but we do have discounts available to you.
Awesome. So I think you've covered all of the labs. I do want to ask you, what is PCOS and how is it diagnosed? What are some of the symptoms? I know I covered it very quickly, but can you go into detail?
Yeah. So it's more of an endocrine disorder more than it is anything else. There's actually, a big issue going on questioning that right now, because it is a misnomer, the name. Not everyone with PCOS has cysts on their ovaries. Yes, it is called Polycystic Ovarian Syndrome. They're considering changing the name. No one has been able to decide what it should be called, but because it's kind of a misnomer in that respect. So what it really is excess testosterone in a female that drives up fat deposition and insulin resistance. And one of the biggest mistakes I see made is a provider that doesn't know that biochemical pathway will say, well, you don't have insulin resistance yet. You're gaining weight, you're obese, but I don't see it on your labs yet. So I guess we just won't treat you with anything like metformin or semaglutide or anything that would treat the weight gain. But you don't wait until the person is insulin resistant to start treatment, because that because they're gaining weight, that's already happening. Okay. And it's only a matter of time before it shows up on labs. So that's kind of the progression. So you might start off as a thin phenotype, which you appear, that's what phenotype means to the outside world, would be like thin, you could have acne or just a few chin hairs and thin hair on top of your scalp. But because you're not obese, some providers would be like, well, you can't have it. You're not obese. That's a misconception. And unfortunately, that's how I started out. I was 18. I was very thin. I was like 120 pounds. But what 18-year-old female has hair popping up on their chin like a menopausal woman, hot flashes, My part was almost an inch wide on my head. Acne when I didn't even have acne when I was in puberty. Right. So these are all red flags. And yes, it took every year I gained like 10 pounds. Like, eventually by the time I was in my late 20s, I was, on the obese level at that point, because no one would, would treat you till you get to that point. But you shouldn't let it get to that point. There are protocols, and, that's what needs to be followed. So that is the root cause, is excess testosterone. And then a big question I get is, well, they checked my testosterone and it was not high. And this is also confusing. So yes, we always check it, but it's actually not required for diagnosis. You have to have, it's now a diagnosis of exclusion. So you have to exclude every other cause, okay, for these symptoms, which would be pituitary brain tumor, adrenal tumor, something called adrenal hyperplasia, okay? And then as long as you have the symptoms in 2 categories, and that is hyperandrogenism, so having unwanted hair, scalp hair thinning, acne, and the second is irregular cycles, you don't have to prove biochemically on a lab that your testosterone is high. And the reason why this guideline changed is because we know now it fluctuates from day to day. So could you imagine in the early 2000s, a woman coming in and she had a full beard up to here. They checked her testosterone and the doctor says, you know what, I can't help you because it doesn't show it's high. That's what would happen. And these women would go decades getting, progressing, gaining weight. Eventually, obesity leads to diabetes, heart attack, stroke, high cholesterol, infertility. So really, that guideline, it should have been what it is today, which is, yes, we check it, but it's not, you don't have to meet that criteria as long as you have those symptoms. And then even for irregular cycles, let's just say you don't have irregular cycles. Okay. And they are very regular every month, but you have all other symptoms. And then we will do, a transvaginal ultrasound or an AMH, an anti-Müllerian hormone test, which is the newest test that just came out, that basically makes it so that you don't even have to do the transvaginal ultrasound anymore. So you don't even have to persist. The new test came out. You don't have to do that. You can do either or, but I can tell you, if you ask a woman, would you rather have a transvaginal ultrasound on a table, or would you just rather have a blood test? They're going to say blood test, right? Every time.
Right.
So that's a little bit confusing, but the biggest problem is missing those rare but serious diseases like brain tumors and adrenal tumors. And that's what happens when somebody doesn't follow these guidelines.
Wow. So I have a question. Mm-hmm. If a woman doesn't have a regular period, that doesn't necessarily mean that she has PCOS?
You mean if the periods are actually regular every month?
Correct. That's what I meant. If she has a regular period, but she's dealing with all the other symptoms, how would she still have PCOS?
Possibly, yes. Because actually, when I had all those symptoms myself, when I was 18, my period was regular every month. See, that's what threw them off on the diagnosis back then. But it turns out when they did the transvaginal ultrasound, I had the total polycystic pattern. Okay, it's like a grape like cluster pattern. But now if I had been diagnosed in current times, we actually have a blood test called the AMH that would have been perfect for someone who didn't have that irregular. I know it's confusing when you said it's like a regular or irregular cycle, but for the person
that's what I meant.
The irregular, it's the same. That everybody gets confused with that, but yeah, so there is an alternative. Okay. And then that's another thing that is confusing is if you're on current treatment, let's say you're on birth control, you can't go back in time and do the testing. Okay. And say, okay, but do you have it now? Because that birth control will mask your symptoms and mask your blood work. So when you
wait, back up.
Yeah.
That's very interesting. So if a female goes to the doctor with an irregular period and they put her on birth control, that masks the test that you would then try to perform to see if she has PCOS?
Correct.
Can you talk about that?
Yes, this is a big problem. So you can't go back in time and say, okay, well, we should have done that back then. What are we going to do now? So it actually becomes very difficult in clinical decision making for both the provider and the patient because ethics gets involved. So if you know somebody probably has cancer, but the first oncologist they went to didn't do the right test, do you take them off of their treatment just to prove a point? Right? It becomes ethics. Like we took an oath, the Hippocratic oath, like not to cause harm. Right. So that provider and the patient, the provider has to be honest and say, look, you've been on birth control for 10 years. Your labs are probably going to be not what they really would be if we took you off. So what I do is, this is through experience. You have to go to a very experienced provider that understands hormone interpretation. I typically will double interpret the value knowing that it's probably double what it is if they weren't on the birth control. Mm-hmm. And then I still do all the pituitary and adrenal tumor rule out tests, right? And so I know that if somebody is borderline, like if their DHEA is through the roof and it's almost to the point where I would do a CAT scan, to look for an adrenal tumor, but they're on birth control, I'm like, if you're on birth, it shouldn't be that high. It shouldn't be borderline high at all, right? So in that case, it becomes a judgment question for the provider because it's unethical to take them off. Now, the patient might say, no, I want you to take me off of all these meds just to see. And at that point, that is a, joint decision between, the provider and their patient, and they're willing to do that. But I always tell my patients, okay, it's going to take 3 months for any hormone change because of pituitary gland biofeedback. So you're going to stop the treatment, the birth control, and you might be like, wow, I'm cured. Everything's fine. But 3 months later, all the symptoms start coming up. And guess what? It takes another 3 months to get it back in your system. So you could end up having a 3 to 6 month period of suffering to prove a point, and I do warn them that can happen. Your hair can start falling out again. The hair can get really bad on your face. So I'm comfortable interpreting the labs while they're on the medication, but not all providers are. It gets very complex. And this is why providers should be following the guidelines from the beginning, not later. But of course, you do inherit these patients that you can't help it. They came from somebody else. Yeah. And that's the decision, it's difficult.
That is a difficult thing, but wow, you're very thorough, and I had not heard that before. But this is the reason we partnered up, because I've had other experts talk about these things, and I haven't been able to find anyone that's super thorough and able to do and talk about what you just said, because let's face it, we're all different. Everybody is unique. And I have yet to find a doctor, a specialist who understands PCOS like you do. So thank you for explaining that. We talked about the latest in the treatment. I have my notes here so that I don't leave anything on the table. And I wanted to ask you, in order to diagnose PCOS, you have to rule out every other cause for the symptoms. We just went through that. The tumor. Is PCOS always diagnosed, or do some women go years without being properly diagnosed?
I have some women that are now in their 40s just getting diagnosed. It's pretty terrible. By then you would have surely progressed into the overweight or obese phenotype by then. Oftentimes they have full-blown diabetes at this point. They could have high blood pressure, high cholesterol, never could have children. Some of them are actually misdiagnosed with bipolar disorder, borderline personality disorder, because at this point their testosterone has been so high. I mean, that's a whole nother topic, but it can affect, cause mood swings. Because think about it, like even you've heard about like men abusing injectable testosterone, right? Yeah. So it's more than their body can handle. So women that have excess testosterone can go through hormone spikes where they could have the equivalent to that, like what we would call stereotypically with a man, a roid rage, or, whatever you would call it. And the same thing can happen. And unfortunately, they oftentimes it's how you refer your patients, right? Yeah. That affects so much. So if your primary care provider says, this is psych, you go down this tunnel, this pathway into psych, and they're not hormone specialists, right? So they're not going to check your hormones necessarily. They wouldn't even think about it. They're not gonna, they might, if you ask them, send you to an endocrinologist, then you have to go back this way, right? So, but a lot of women never leave that psychiatrist. They never leave the psych side of the pathway, and they get stuck there.
What you're describing, I think, is going to wake up so many women in their 40s, because I bet you there are women watching this or will watch this that are like, whoa, this is me. I feel crazy, or I've kind of been misdiagnosed. This is wild, Lynsey.
It's we actually have a lot of psych nurse practitioners who've taken an interest, and they actually refer a lot of patients to us, because as women, a lot of nurse practitioners are female. They're like, I've noticed this. I have some patients that have been diagnosed since a teenager with bipolar and these different things, and they're wondering how much of it is that, or how much of it is hormones. And we've had a few patients that came and we tested their hormones. It was through the roof. And then when we balanced their hormones, they were able to reduce their psych meds a lot.
I'm actually putting this in the chat. This is incredible information. Wow.
So it really affects women long term, because you can imagine by the time you're 40, you couldn't have kids, which is a major lifelong goal for a lot of women. You became overweight, and society puts a lot of pressure on body shaming in the past, and then you can imagine you're losing your hair, you're growing hair on your face. You think about how much of your life was affected by that. So some women are pretty angry at that point when they do get a diagnosis. They distrust medicine. To be honest, sometimes they turn to people that are not certified to provide treatment. Like, there's people on social media that sell, certain supplements that may not be approved, or you don't know what's in it. You really don't know, because they're so desperate, and because they got let down so many times by Western medicine. And we're here to change that, because, technically we are medical, we're nurse practitioners. Okay. So we are following the guidelines. And that's what needed to be done a long time ago, is even in primary care, whether you're endocrinology specialist, you're in GYN, PCOS has no medical home. We all treat these patients, primary care, GYN, and endocrinology, and everyone needs to have background and education in this, not just GYN, not just endocrinology. It's just there, when a disease state has no medical home, it's at risk for being left behind, because it doesn't have a place to live. And that's the problem. Yeah.
Why doesn't PCOS have a place to live? What is it about PCOS that makes it so complex and they just can't figure out where to put it?
It is so complex. It's not just that. If you look up in the history of different syndromes and disease states, there's lots of other disease states that have been left behind and didn't have like a medical home, when they affect too many different parts of the body. That's the problem, because then you don't know, the primary care provider doesn't know exactly where to send them, So I am under, my opinion is, primary care needs to have more education, so they know when it's beyond their scope, if it's beyond their scope, and and if they need to send someone to endocrinology, or if they need to send them to GYN, and when to send them to reproductive endocrinology. And sometimes they don't know, or they don't have the training, and they kind of just, pick one, and it's kind of random. It might not be, and really the first point of contact is primary care. And that's who needs to be trained in how to treat. And then if it's beyond their scope, if they don't feel comfortable and they don't have further training, who to refer to.
That's what I was going to ask you. So where do women start? What should somebody who suspects that they may not necessarily have PCOS, but maybe they suspect that something isn't right, where do they start?
So this is where it gets complex. So it really depends on the provider themselves. So there are a lot of, we are family nurse practitioners. We can treat all ages. We can treat the whole body. which is great because PCOS affects the whole body. And so if you go to GYN and you have high blood pressure or a thyroid disorder secondary to your PCOS, they got to send you somewhere else, right? Because they don't specialize in that. So that's why, to me, primary care is, the best medical home in my opinion. And but the thing is, there's a lot of variation in that. So my nurse practitioners, we have additional training beyond primary care in hormones. We have further education that we have took upon ourselves to gain. So you kind of have to do your research on your primary care providers. Like, what is their background? Do they know a lot about this? It actually takes a lot of research. And then determine if that's the right place for them. And then, because there's endocrinologists that subspecialize in only certain parts of endocrinology, and same thing with GYN. So it's really about researching your provider and seeing what their background is.
I think this is so informative, but I think that so many people are going to throw their hands up because it's so difficult to go to a primary care, and then you have to do your own research on whether or not that primary care knows enough about PCOS, or even are they going to refer you to the proper person?
Right. And that's why PCOSsisters came about, because we were like, you know what, this is a one-stop shop. This person comes to us. We can diagnose them. We can tell them if you have it or you don't have it. And if you don't have it, we can tell you where to go from there, because we are primary care and we are PCOS focused primary care. And if we discover, we do a whole metabolic workup. So if we discover you have a thyroid disorder, if you have high cholesterol, we even do autoimmune screenings, because there's a lot of research where there's correlations between autoimmune diseases like lupus with PCOS. And if you meet the criteria, we even can handle that. And then if it, obviously, if we discover that there is a tumor, we'll do the initial CAT scan. Then we are referring you to get that taken care of elsewhere, because we are not surgeons. We are primary care providers that focus on PCOS women.
Mm-hmm.
But that's what primary care is about. We do the whole body screening. We determine what is going on, and we treat what is within our scope, and then refer when necessary. Mm-hmm.
This is such amazing information. So I have a deeper question. What are the statistics with PCOS? How many women do you think have it? How many women do you think are undiagnosed with it? And then anything else you want to elaborate on? This is something I had no idea we were going to get into today.
Yeah, it's actually pretty profound. So we used to think, before the newest guidelines came out, and they just came out last year, that it was about 6% of women. So you're like, okay, that's kind of high, but it's not strikingly high, right?
Mm-hmm.
Okay, now with the new guidelines, we think it's 10 to 20% of all women globally.
Wow.
10 to 20% globally, all women. And those are the women that know they have it.
Wow.
That's what's so scary. So you could, it's up to 20% of the women that know, that know they have it, that we have data on. That's a lot of women.
That's really high.
Mm-hmm.
Wow, that is crazy. Talk a little bit about what some of the most significant symptoms are. Like, what are the most common symptoms and what are the least common symptoms?
Well, that gets a little bit more complicated, I would say, because it is a syndrome. So the definition of a syndrome is when it's multiple symptoms that not everyone has to have all of them to meet criteria to be diagnosed with it.
That's probably the hardest part, and why they can't diagnose most women, because their symptoms.
Yeah, they vary. So any one of hyperandrogenism symptoms, meaning you have too much testosterone. Okay, so that would be the excess hair growth on the face. That would be the scalp hair thinning in a male pattern, which is like the front, and then acne from excess testosterone. Those are all signs of hyperandrogenism. So you could have just one of those and you would meet that criteria. So I have women that, there's women that just have the acne, or just the hair growth on the face, or just the balding. Sometimes it's just balding, and they meet that criteria. And then sometimes they don't have the irregular skipping cycles or late and early cycles. And then when we do an AMH test or the transvaginal ultrasound, they show up positive with that. So it does get complicated. Mm-hmm.
So, what are some of the ways that you can reduce the symptoms and actually treat? So, I have a silly question. Is
Mm-hmm.
PCOS treatable, or are the symptoms just manageable?
It's treatable, but there's no cure. I think that's the difference, because I have people call that are like, well, if I take this medicine and if I stop taking it, will I be cured? There is no cure. We don't know exactly what causes PCOS. There's a lot of theories. Like, we do know, of course, it runs in families, but do you know if that's because, is there an environmental factor because you all live together as a family? Is it genetic? It's very complex. So we don't really know, which adds to the complexity of it. Yeah. Is where did it come from?
Mm-hmm. Well, I'm hoping that at some point we will be able to figure that out. I'm still stuck on the statistics you just gave me. 20% globally is affected by this disorder. And what you told me about depression and bipolar disorder, and these can all be symptoms of PCOS and being on the incorrect or the wrong medication. And now this poor woman has been dealing with this when it could have been so easily either reversed or managed.
Exactly. And what we offer is personalized medicine, because you have to realize when something is this complex.
Mm-hmm.
I'll have people call and say, well, exactly what is your treatment? What is the treatment?
Tell me what the magic pill is, Lynsey.
Yes. And there is no the treatment. You have to look at the person and realize which endocrine biochemical pathways are activated. So you have to be like, okay, if this person started off as a thin phenotype and then they started gaining weight, you know that the insulin pathway is already being affected. So then you do things like choose between metformin and semaglutide. Okay, if you know that the person is not gaining weight at all and they're the thin phenotype, and it's usually the younger patients, because they're earlier in the progress, and then they'll have like acne, hair growth, issues or lack thereof on the scalp, other things going on. And for them, you might give like androgen blockers or something that specifically blocks testosterone at the hair and skin receptor site. And then that can prevent them from the excess testosterone driving up the fat deposition and activating the insulin resistance pathway. Like, if you catch it early enough, which I know with a lot of your patients with electrolysis and hair removal, they could be technically be young and just have the hair growth. They might not be overweight or obese yet. So we would treat them differently because they haven't progressed, which is the best situation. You can catch it.
So, just to answer my question, can somebody who comes to see you be permanently, I guess you said there's no cure, but like if it's a younger woman, let's say in their 20s, can this PCOS situation be reversed? Can she live pretty normal life, get pregnant, not have polycystic ovaries? Is that possible, or we don't know?
Oh, no. The medications, when you treat PCOS, you become more fertile. But naturally, you naturally will become more fertile. And so we have different strategies we use for that, because some medications are great for PCOS and increase your fertility, but are not safe for the embryo itself. One of which is semaglutide. So we have to let the 2-month washout occur before we can tell them, okay, now start trying to get pregnant. And so we do assist patients with infertility too. So we get several patients a year that have been to so many specialists, reproductive endocrinologists, like all over the place, and could not get pregnant. And then we treated their PCOS and it happened naturally. The thing is with the treatment is I rarely have a patient that can stop all medications for the rest of their life once they reach their goal weight and the symptoms are controlled, because there's an error somewhere in your endocrine and metabolism. We don't know, no one's identified exactly where that is. But if you stop taking the medicine, at least one of the medicines, some people are on 1, some are on 2, some are on 3, depending on how bad your PCOS is, Most of my patients have to take at least one of our medications for the rest of their life to maintain the status quo, to keep it. They might not have to take 3 meds for the rest of their life, but we monitor your hormones and we measure them and make sure, like, okay, well, we like to use the least amount of meds possible. We are very holistic. We don't like to just put somebody on the highest dosages of everything, say go home. You know, we start you off at a low dosage of any medicine. That's just the principle we follow, and increase it only when necessary. And then the goal is to wean you down and hopefully not have you on the bare minimum medication to control your PCOS. You know, we don't like polypharmacy and just, you know, giving somebody a handful of pills. That we do not like that. So we also have the workout program built in, and also the meal planning, because that's another question I get is like, well, if you give meds, do I not have to exercise? Like, how does all that work? And it's really, but you have to do both. Okay. Because, and this is why people are like, well, why is that? Because if you fix this error in my metabolism and the testosterone pathway, then shouldn't I just not have to do anything? I can eat whatever I want, whatever. And that is not the case. What it means is when we treat your PCOS, you will respond to diet and exercise like everybody else. So women will always say, I don't understand it. I work out 5 days a week. I eat literally barely one meal a day. I eat like a pack of tuna and an apple or whatever it is. And you're thinking this person should be anorexic. Like when they tell you how they're living their life, and you realize this person is still overweight or obese despite that. And so a big problem that's happened in the past is what's called medical gaslighting, where their provider would say, well, this person has to be lying. There's no way you're exercising 2 hours a day, 5 days a week, and you're still 200 something pounds. Like, and they basically call them a liar. So, you know, that's called medical gaslighting. And now that we have things like tracker, you know, you can track on your watch, you can show what you're doing. You can be, look, no, do you see this? I'm doing all these steps. I'm eating well. And that's kind of slowly going away, which is a really good thing. But when you treat your PCOS, when you work out, like the textbook says, like, oh, just, you know, 2 to 3 days a week, and you eat a normal, healthy diet, you will see the weight come off. You will respond. The testosterone isn't fighting you like it did before, making it impossible to lose weight. So
is that what basically happens to PCOS ladies when they're, because I know some ladies who have PCOS and they barely eat, but they can't drop the weight. So you're saying that the testosterone is fighting the weight loss for them? Metabolically, that's what's going on?
Exactly. So until we treat that, you will not have a comfortable response, right? I mean, there are people that are like, you know, you see them on Instagram, I cured my PCOS with just exercising and just not eating, and they're always on a keto diet or whatever it might be. But you have to realize that's not sustainable nor healthy for the average person. Keto diet is not recommended for PCOS. It actually puts your body into starvation mode. And when you quit doing it, you can actually get rebound weight gain. And because PCOS is in some ways very much a pre-diabetic condition if it's untreated, right? So I always recommend the diabetic diet, even if you don't have diabetes. You know, it's very fair. You get a starch on every plate. You know, you don't go without starches entirely. It's just the whole half the plate isn't, you know, potatoes. It's very reasonable. You can completely live the rest of your life that way without feeling restricted. That's a big red flag. You got to stay away from these restriction diets. So a lot of people will preach, well, cut out this, cut out that, cut out dairy, cut out gluten, cut out, and pretty soon there's nothing you can eat, you know, and then that, you think that person can live their life that way? I mean, there's a few people that can, but, you know, most people cannot.
No.
They eventually fall off the bandwagon. And the same thing with extreme exercises. Yes, you can fight the testosterone in an uphill battle by barely eating and working out for 2 hours a day, 5 days a week. But I can tell you very few people, we're all human, can live that way. And that's the problem. It's not sustainable. So
you don't need to. The beauty of it is you don't need to, because we have you as a resource and PCOSsisters who can help women get on the right track. And like you said, we're all different. So the first step is to contact PCOSsisters via telehealth call. And then what happens after that? You have a consultation. Explain how this process works to people who are listening.
Yeah, so it's super easy. So you can book online. You can book if you're ready to get started after you've listened to the show or you've gone online and researched us. Then you can go ahead and book an appointment, and you can actually see the nurse practitioner schedules. And beside every nurse practitioner is the state that they operate in. So you just have to choose the state that you're going to be in at the time of the visit. And then you'll get an email link with instructions, consent forms, intakes, portal access, all that good stuff. Now, if you're on the fence and you're like, okay, I looked over the website, I'm not yet ready to make a decision if I want to book an appointment, you can do at the top. There's a free consult, a free phone consult. That's a 10-minute phone consult with one of our providers. And it just answers. Now, this is not a full visit. They cannot order your labs. Okay. They cannot order your meds. They cannot provide you a full treatment plan. They can discuss any questions you would have. They can tell you about what we offer, kind of go over what I'm telling you today, kind of go over like how PCOS works, how we can help you. And that's a free 10-minute phone consult. And that's really nice because you can learn. I mean, it's hard to sign up for something online that you haven't, you want to make sure it's real. You want to meet with the provider and make sure it's right for you. And I think that's really important.
Absolutely. Well, that's great. I think just the accessibility of what you've created, Lynsey, honestly, is beautiful. And I'm still a little bit taken back and in shock about providers not being able to diagnose women with PCOS. And so they send them to the wrong specialist, which, gosh, that can be devastating.
It's
and take years.
And that's why a lot of our patients are actually, they'll say, I am my own researcher. That's one of the first things when they call a vote. And you're like, wait a minute. I told my receptionist, I was like, no, that's pretty typical with PCOS patients. We have had to do our own research. And so they actually bring a lot of interesting questions to the table. A lot of them are very well informed. These are women that want to get to the bottom of it. They want to treat the root cause. They're tired of Band-Aids. They want to know what is causing it and treat it as they've suffered many years. And so, but by the time they get to us, they've already seen several other doctors usually at that point.
Yeah. It sounds like people who come to Beverly Hills Hair Free, they've already spent thousands of dollars on lasers and other forms of hair removal, and they still have hair and they're not happy about it.
Exactly.
So let's segue into the hirsutism part and how that relates to PCOS and why you and I partnered up together. I think this is going to be an amazing partnership because oftentimes we get people in our office, we're their last resort. They've spent so much money trying to fix the hair issue and they still have hair. Some of them end up with more hair when they try to get rid of it. So that's devastating for them. And they also have done their research. So let's talk a little bit about that facial hair and the body hair and the male hair patterns and what to expect with PCOS sometimes.
Yeah. So what the best thing to do, so one of the things when they come to me, a lot of them have gone to have laser. Okay. We do not recommend laser. Okay. Because laser can actually cause, specifically, it's more common in PCOS patients, something called hypertrichosis, where the heat, and I know, this is your specialty, so correct me if I'm wrong, the heat will stimulate new hair growth while the hair that you see might fall out and you're thinking like, oh great, it went away, it did its job, but then at the same time the heat stimulates new hair growth, so it's like this vicious cycle.
So I'm going to correct you real quick. It's actually not the heat. We now know that it is the photons, and you'll know this. Our skin and blood supply absorbs up to 40% of whatever we put on it. And that stimulation, when you already have overstimulated androgens, will do the opposite. So that's what actually happens.
Okay, so that makes sense.
Yep.
That makes a lot
And
of
it's called
sense.
paradoxical hypertrichosis. It's not the heat, it's the effect of the absorption in the blood supply and the skin that causes that unfortunate reaction where women will end up with more hair than they started with. And it is devastating. Happens on the face. It happens, I've seen it on the upper arms, and I've seen it on the sideburns, mainly the this part of the face right here, upper arms, lower arms, and the upper part of the body.
Right. It's pretty devastating. And we get the patients that are like, I've probably spent $10,000 on laser, this, thousands of dollars on laser, and it always comes back. And that's the frustrating part. And no matter what hair removal process you use, if you have PCOS, you need to treat the PCOS first by taking something that will lower your androgens. Because if you don't do that first, no matter what you do, you can always get new hairs, right?
Yep.
But the interesting thing about having PCOS is, so I'll have women that are like, okay, I've had untreated PCOS for like a decade, like a really long time. And now they have a lot of hair. It was just like a few chin hairs. And what you'll notice is the hairs that have been stimulated by the testosterone the longest. And if you ask them, it's usually the hairs that they first had 10 years ago.
Mm-hmm.
It's like fertilizer on a tree. Right. So
that's a great explanation.
Yeah. I said, well, it'd be like if you had an oak tree that's been around for 200 years, and I'm from Savannah, Georgia, so I'm used to oak trees. It's been around a long time. So, and you're putting fertilizer on it every day and you try to yank that thing out, it's not going to come out. Right. Mm-hmm. And if you try to do anything to it, it becomes more difficult. So what we do is, if it's been a long time, what you'll see is usually in about 3 to 6 months, because every hair is in a different growth cycle, as you know, mm-hmm. You'll see them thinning and they get better, and it's in reverse order. The more recent hairs and then the oldest hairs. And sometimes there is, more often than not, if you went a long time without treatment, you've got a whole grove, we'll call it a grove of hairs from the original back in 2003 when you had really high levels of androgens, and that they are very stubborn. And I tell people, if we've already put you on the androgen blockers, if we've treated your PCOS and we measure and check your hormones and it's now in a normal level and you've noticed some thinning, but there's still some stubborn hairs, then that's when you need to start thinking about a hair removal process. And I tell them not to do laser, of course, the reasons we talked about. Mm-hmm. And I always tell them that electrolysis is the only FDA approved hair removal process. And so that's when I send them to you.
And we can help them. Mm-hmm. I'm going to pick up a little bit of where you left off. So talking about hair removal and stimulating new hair growth and all the other options that are out there. Yes, electrolysis is the only, in fact, permanent hair removal method out there. And we have a system that utilizes 16 to 32 probes. That's the uniqueness of Beverly Hills Hair Free. We don't use one probe at a time. We use 16 to 32. We also offer pain management options to keep you very comfortable, so that if you have a lot of facial hair and you're nervous about the pain aspect, don't worry. We create custom treatment plans that suit your specific lifestyle, your personal needs, and it works in a very unique way. So, for example, someone that you would send over to us, the initial point of contact, we ask for photos. The photos help us to assess how bad or how not so bad the situation is. I always like to know what I'm walking into. Just like you, Lynsey, you ask for blood work. That's how you can read the person's information. We ask for photos so that I can see everything I need to see, whether they have upper lip hair, chin hair, sideburns. If I spot anything that they may have missed, I want to make sure I can see everything underneath the neck and the underneath the chin and the neck area. And if there's anything else that I'm noticing, whether it's acne or skin damage or anything I need to know that helps me create the treatment plan for the client, for the patient. Mm-hmm. And then we'll have our initial consult. They don't need to come to our office. Everything is done via phone. And if they don't live in Beverly Hills or Texas or in Arizona, it's okay. We can set up a treatment plan where you're coming in to see us once a month. And I know people are like, wait,
That's
what?
great.
Usually electrolysis once a week, 30 minutes, or twice a week, or every week, or every other week. We don't need to do that. We like to keep you in our office as long as possible, once a month. It's very effective, again, because we use up to 32 probes. When you're comfortable and you're not in pain, you can give us 2, 3, 4, 5 hours in our office. And then we send you home. If we can send you home completely hair-free, that's how we're going to do it. If we can't, we send you home with a little bit of hair left on your face. We can either wax that off for you, or we can leave it alone. And the next time you come, you're coming back in a month. So people who say, oh, I can't be there, I don't live in Texas or Beverly Hills, you can do once a month. And if you can't do once a month, we will try to get you as close to 4 to 5, 6 times a year so that we can make it as effective as possible. We understand that you have different lifestyles. You might have to travel. Sometimes finances are an issue. We work all of that out to make sure that we can get you hair free in just 18 to 24 months.
Right. And I think that's great, because like my patients, we cover the whole state of Texas. And, I know you have the clinic in Dallas. So they could potentially be from other areas, or even fly from Atlanta once a month. It does work. Once a month is definitely different than every week. Because when I tell my patients every week or every 2 weeks, because some of the electrologists locally might not have this new machine available, Pro machine. And they're like, oh gosh, I can't do that. That's too much. Atlanta traffic, whatever it might be. And this is really innovative because they don't have that problem. They could just do once a month and be done.
Exactly. So yeah, this is the beauty of multi-probe galvanic electrolysis and the Beverly Hills Hair Free System, is that we don't want to see you every week or twice a week. We want you to spend as much time in our office when you come in. And by the way, I should mention, we have a national and international clientele. We've had people fly in from as far as Norway, Dubai, Puerto Rico, East Coast, West Coast, and we don't have a problem treating clients from anywhere in the world. We will ask you, Australia even, will ask you for photos. Those photos provide so much information for us that if you're traveling, let's say from an international country, and you need to be here 2, 3 days, we can actually do that too. And then you go home and you recover. Which brings me to my next point, is there is a little bit of a recovery. You may have some scabbing. We ask that you don't touch your face. Use the aftercare we provide. It can take up to 7 to 14 days for you to recover. And then your skin is beautiful and ready for your next treatment. The other thing I do want to share, and you might know this, is shaving does not grow more hair. It's a myth.
I was about to ask you to comment on that. I was like, because my patients are always asking me, can I shave? Can I pluck? Can I wax? Like, can you elaborate on that a little more?
So let me talk about plucking and waxing. You cannot do when you're starting electrolysis. And the reason for that is if you pluck a hair, it's not going to grow back the next day. It takes about 3 weeks for that hair to come back. So if you're plucking, but you have an appointment in a week or so, the reason we ask you not to pluck or wax is I won't see those hairs. So you're not going to have a very effective treatment. And we want you to get the most bang for your buck. So while you're in our office, we want to be able to see all your hair, treat all the hair, and get you on your way. If you're plucking or you're waxing, you're not going to have all that hair when you have your treatment session. So we need you to stay away from those. You also can't do laser in the interim. The reason we ask you to shave is for a couple of reasons. First of all, shaving does not cause hair growth. If it did, I just discovered the cure for baldness. Think about that.
That's true.
Let's just shave every bald man's head, take their money, and we just discovered the magic pill. It doesn't work. It's a myth. But what shaving does do, and why people think it causes their hair to grow thicker and coarser, is because the razor is meant to cut your hair at an angle. So when that happens and you go, ooh, that's really prickly, it's just the way the razor is designed. Trust me, it's not going to change the diameter of your hair. It will not grow any more hair. But what we want you to do is we do want you to shave your hair a little bit before, like 4 or 5 days before you see us. Couple of reasons why we do that. The first reason is it's when we use 32 probes, we move very quickly. And if those hairs are together and intertwined, it's like weeding through the forest. It really slows us down. So that's the first reason we ask you to do that. The second reason is you yourself will know if your hair is really long, it actually looks like you have more hair than is there. If you shave the hair, you can actually get a really accurate idea of how much is there. So we never want someone to send us pictures with their hair intertwined, because we're never going to be able to give you an accurate treatment plan. The other reason, and this is for the patients themselves, your treatment is 100% effective when your hair is short, because that hair is almost guaranteed to be in an active growth cycle. If you're treating long hairs, we don't know if it's about to fall out. We want the hair underneath that hair, but it's harder to get to it because the hair that's falling out needs to come out first. Right? So that guarantees a more effective treatment when the hair is short. We're able to insert our probe all the way down to the subcutaneous layer. And then the other reason is when your hair is long and it's moving up in the hair follicle, the current is being released between the skin. It's not going deep enough, and then you're feeling more pain. So sometimes when clients are like, oh my God, it was so painful, that could be a reason why. Is a lot of electrologists won't tell their patients to shave your hair a few days before they come in to see them. So sometimes when the current's being delivered in the wrong place, it causes more pain.
Gotcha. And I know, like, for us from the medication perspective, the hair growth cycles even affect what we're doing. So a lot of people don't realize that, because no matter what treatment you're doing, the hair has to be in an active growth cycle. So that's why even when I give androgen blockers, this is the biggest reason for failure. They'll take it for a week and they'll say the hair is still there. And I'm like, no, it takes months, because every single hair has to be exposed to that medication that you're taking every day. You have to take it every day consistently to see any effect whatsoever, even the slightest.
That makes sense.
The same thing with you. The same thing with you. The hair has to be an active growth cycle. And I was wondering, so what is your theory on when the hairs, I've heard, I don't know if this is true, with plucking hairs, distorting the hair follicle and making it less responsive to any kind of hair removal just because it distorts the follicle. Is that true, or how much?
In my experience, that is not accurate. We ask people not to pluck because the reason is when we tell people to stop plucking, they think they're plucking the same hair every day. So we always caution them, when you stop plucking, you're going to see hair you haven't seen in a couple of days, weeks, months. Don't freak out. We need to see that because it gives us an accurate idea of how much is actually there. Do I want you in my office for an hour or 5 hours? I have to be able to determine that. Whether or not it distorts the follicle, with multi-probe galvanic, we haven't found that to be true. It's not more stubborn, or maybe it's just because multi-probe galvanic is actually the best method for stubborn, ingrown, deep terminal hair. But I have not found that in my experience. No.
Yeah, because I've heard different things from different electrologists, and it might be that the single probe, correct me if I'm wrong, the single probe that you have to go in every week or 2 weeks to do, that's not galvanic, right?
So it can be galvanic. You can, I'll give you like a quick little understanding of it. Galvanic electrolysis can be used with a single probe, but because it's so slow, most electrologists don't use it because we have 32 probes. And so if it can take us up to 4 hours to get a lot of hair, it can take about 12 hours for a single probe to do the same thing with galvanic. That is why most electrologists utilize thermolysis. But yes, you can do galvanic with a single probe. It just takes forever.
Yeah, so that's what I noticed a big change in the few hairs that were stubborn with me because I was
Hmm.
untreated for so long with galvanic versus
Yep.
the heat, basically the thermolysis. So I didn't see a lot of results until I did galvanic,
Hmm. And
but
I'll
it
tell
was.
you why that happens. Yeah. So in my experience, galvanic creates lye inside the follicle. And so what happens is the tiny little probe gets inserted into the hair follicle, and then a current is released, mixes with the salty tissue in our bodies, and creates sodium hydroxide or lye. That lye continues to circle inside your follicle. Even once we remove the hair, it's still working in there to destroy the stem cells. We don't know where those stem cells are. Anybody who tells you that they hit the target, I'm sorry, has no idea where that target is. You can't see under the skin, Lynsey,
Yeah,
you
that'd be
know,
hard
and
to angle a probe
we
and
don't
see
know.
that.
And we don't know if those stem cells, and we know they migrate. You've seen charts, right?
Mhm.
Stem cells migrate. They might be moving up in the follicle, they might be over to the side. Nobody knows. And there could be lots of them, not just one. So I always like to tell our clients, think of galvanic as water.
Mhm.
What happens when you put water in a test tube? Think of your follicle as a test tube. You put the current in the salty water, it creates lye, and it literally seeps into everything.
Mhm.
This is why it's so effective. When you're using heat, just like when we're using galvanic, we have no idea where those stem cells are. You have to hit the target when you're using heat, and we
Mhm.
don't know where that target is. So I kind of equate it to, you're shooting a basketball with your eyes closed. You'll probably get a few shots, but what about all the
Mhm.
ones you miss?
Right. Okay, that's a great analogy because that's kind of what I experienced. Like it helped a little, but then when we had the galvanic, it was like, whoa, whoa, this is a
Yeah.
huge, huge change.
Yep.
But that is something I guess patients should be informed about when
Yeah.
they choose their electrologist. Like even if they can't see you and they go somewhere else, they need to, ask questions about these things.
Yeah. They
Hmm.
absolutely do. And it's difficult to navigate. Not everything works for every person. And I will say that because some people are not candidates for multi-probe galvanic. They don't want to stick it out. They don't want to spend a 5-hour session in our office. And that's why we have options out there. But if you have tried other things and it didn't work for you, multi-probe galvanic, Beverly Hills hair-free system. We call it a system because we know what you're going to expect when you walk in the door. Our process is always the same. Our treatment plan's a little different, but we know when you come into our office, 18 to 24 months, you will be completely hair-free permanently.
Wow, this is exciting. I cannot wait. I know my patients, like we recently last spring expanded to Texas. So
I love it.
they're just now finding out about you. So, oh my gosh, I'm very excited for what the future brings for sure.
I'm very excited about our partnership, and I'm so
Yes.
grateful that you contacted me, and then we got in touch with each other. You told me what you do, and I was like, wow, this is brilliant. A telehealth PCOS specialist that you can access by just being in the states where you all have your operation going. That is brilliant.
Mhm. Mhm.
And we plan to have a BHHF, a Beverly Hills Hair Free, in every major city in the next possibly year and a half. But again, you don't have to live in the city in the city where, we are located in order to get treatment. You don't have to suffer. You don't have to rack your brain about how it's going to work. We treat you once a month. You can do it. It's totally doable. If you can't give us once a month, we can work it out to where you're coming in 4 or 5 times a year. Just remember, it'll just take you longer to get permanent results. But is it going to work? Absolutely.
Exactly. Exactly. This is awesome.
This is awesome.
Yeah.
I do want to just end, unless you have something else to add, but I learned so much from you today. I had no idea all these sufferers were.
Yeah.
Wow. And
It's a,
20%, that's a very high number for me.
it's a
But
lot.
it makes sense because when I started doing this about 27 years ago, I was seeing maybe one or two PCOS patients, and
Mhm.
I think that's quadrupled over the last 27 years.
Yeah, and it is interesting. They're trying to figure out, is there something in our environment changing?
Yes.
Is it more people are getting diagnosed? We know it's always been around on some level, right?
Mm-hmm.
You know, because obviously, you know, the quote unquote bearded lady, you know, just all the things throughout history, we know it's been around, but is it more common now, or is it more people are reporting it? We also, medicine, you know, modern medicine is relatively new too, when you really think about it, like the past couple hundred years. Like, it's like priorities. Women's health has always, just recently became a priority too. So there's so many things to tease out, but you know, we're definitely seeing it more often, for sure.
That is crazy to me. I do want to drop a link to where people can find you. So
yeah,
what is your website?
So it is PCOS, okay, Sisters, SISTERS.com.
Very easy.
Plural.
PCOSsisters.com.
Super easy to remember.
Super easy to remember. And I will post some information on our social media about how people can get in touch with you. You're so lovely and you're so knowledgeable, and I'm just blown away by the information you shared with us today. And I know that when this lives on the YouTube channel, there's going to be many women who come across this and they're going to be blown away by the information you shared. But now they have resources, and that was, I think, both of our goals today, is to share medical resources. That's your expertise. And permanent hair removal resources. That's our expertise.
Exactly. I think we met our goal today, for sure.
We did. Is there anything else you want to share before we it's been a little over an hour?
Yeah, I think that's about it. But of course, if they have any other questions, they can always refer to my website. We've got a lot of education on there. So.
Yeah, you sure do. Well, thank you so much, Lynsey. You're a pleasure. You're so well versed in PCOS, and I'm so grateful that there's, you know, a partnership between Beverly Hills Hair Free and PCOS Sisters, and we'll do more of these as we decide, you know, what we want to share the next time, especially once people start to reach out to you and me, and we know kind of, because I always ask my patients, like, what was it that brought you into our office? And because, and this might be for you as well, because I'm so into the electrolysis and hair removal part, sometimes I miss what people are most looking for. Does that make sense?
Yeah, because there could be a you know, oftentimes is a larger issue that's causing the hair growth. So,
yeah. Well, thank you so much for sharing your wealth of knowledge with our audience and myself. And I'm going to let you go because I know it's late your time. It's dinner time. And yeah.
Well, awesome. Well, thank you so much, Alana. Thank you for having me. And we will talk soon.
Absolutely.
Thank you. Bye-bye.
Bye.